Welcome to the Johns Hopkins Medicine online webinar series. Today, Johns Hopkins male sexual health expert, Dr. Arthur Burnett, will be speaking about erectile dysfunction causes and treatments. Before we get started, we'd like to provide some user tips so that you are comfortable using this platform. The first 30 minutes of our program will include an informative presentation by our presenter. The last 30 minutes will be dedicated to our live Q&A session. Please note this program is being recorded. To submit a question, please type your question into the Q&A box and click send. Also, your email address will not be shared with any third parties. We will do our best to answer all questions we receive during the Q&A session. Alternatively, you can email us questions and feedback to hopkinsseminars@jhmi.edu. And at the end of the webinar, we would greatly appreciate receiving your feedback and ask that you complete our survey. A pop-up window will appear at the end of our program for you to complete the survey. And we apologize for the delay today. I would now like to welcome Dr. Arthur Burnett to begin our presentation.
Well, good afternoon, everyone. Thank you for that kind introduction. As mentioned, we're talking about the topic of erectile dysfunction that affects males, evidence-based causes and treatments. Now, with respect to American women, men have the following. They die 7 years younger. They have more leading causes of their mortality than women. They have chronic diseases. They're more than twice as likely to have cardiovascular health disease. Next slide. But they are responsible for 8 of 10 car accidents. And this was an example of a car accident where perhaps there was a distracted driver. Well, this makes the point that men do have other health conditions and they're concerned about their ability to have sexual function. And of course, they may be aroused by a lovely woman. Next slide. So this talk then refers to male functions. And this will bring in all of these concepts about male health and how it impacts sexual function. This slide I think is helpful because I'd like to present to you the fact that male sexual function is a complex matter and we should dissect it apart as to really what are the elements of a man's sexual response cycle. This slide nicely shows that. The functions here include sexual libido, which is sexual desire, erection, which is arousal, ejaculation and orgasm, and then a resolution phase, perhaps after a sexual encounter. So these are really the components of the male sexual function cycle, and there are related disorders to each of these functions. And libido issues, decreased libido or excessive libido. For erection problems, they can range from erectile dysfunction, which is the inability to attain and maintain erections, a prolonged erection disorder known as priapism, or even deformities of the penis, which you may be hearing about called Peyronie's disease. So these are the disorders related to erections. Orgasm, there's disorders of orgasmic function, and I won't read all of those but you can see these relate to dysfunctions there. And then perhaps disorders if the person is not satisfied with their level of function. Today, we're talking about erectile dysfunction, and clearly this relates to an erection disorder. And I wanted to be clear that we are specifically talking about that level of a man's sexual dysfunction. Next slide. So poll question. Have you or your partner been diagnosed with ED, erectile dysfunction? Yes, no, or not sure. So yes has it at 76%, some not sure at 24%, and no 0. So it looks to me like we have an audience that would benefit from our discussion today. Thank you. All right, so let's talk specifically about erectile dysfunction, a more euphemistic term than the term we used to use. The term we used to use was impotence, which I never really liked because it has such kind of negative connotations there. But we wanted to be precise here about what the problem is with an erection disorder. So by definition, this has to do with inability to achieve an erection, a penile erection that can be used for sexual activity, and it is associated with the arousal phase of a man's sexual function cycle. We acknowledge that this is a subjective complaint of the patient, knowing that there are underlying conditions, but really it's almost a symptom of inability to function, and that really is a subjective complaint. And then let me just also mention that this is not a trivial problem, just by way of just population statistics. 30 million men in the United States and 152 million worldwide, which is approximately 20% of adult males, do have this condition. So not trivial, important, and impacts a lot of men. Next slide. Now, what are some of the risk factors? Now, this is important because it used to be thought that it was a disorder of aging, a hormonal problem, maybe a relationship problem, or something psychological. I think we have really understood now in the past 2 to 3 decades, as we've studied the problem fairly well, that there are related conditions that really are true, maybe disease states that are related to erectile dysfunction. And much of this can relate to cardiovascular disease. You can see a whole list of items here, including diabetes, that can affect vascular function. In fact, we use the word almost in a joking way, penile vascular dysfunction, as much as we use coronary artery dysfunction or peripheral vascular dysfunction and all these sorts of terms. But the erection response does involve blood vessels, and therefore disease states that can affect the vascular system of the body are highly related to having erectile dysfunction. Next slide. So next question, have you or your partner been treated for prostate cancer? Yes or no? And so it breaks down here that the majority of individuals responding, 70% say no, 30% say yes. Now, the reason I ask this is because we're going to get into how prostate cancer is related, but this is relevant to the audience. Thank you. So the reason I mentioned prostate cancer is that we know that the interventions that we bring to managing prostate cancer, as surgeons, as I am for prostate cancer surgery, radical prostatectomy, or my colleagues in radiation therapy, the radiation oncologists, they may treat prostate cancer with radiation, or even some of the medical oncologists who have to implement other therapies, such as shutting down a man's hormones to help control prostate cancer. All of these interventions, all of them, can impact a man's sexual function, and it can harm his erections. So what I show on this slide is the fact of the matter that prostate cancer surgery does have its associations. It can relate to the impact of the surgery, the prostate being in a very precarious part of the body toward the root of the penis, internal to the pelvis. And so doing a prostate cancer treatment, there could be injury to the blood vessels or nerves that are relevant to how the erection process occurs. So, when I discuss this matter with patients after treatment, I inform them that yes, there are going to be some risks with the surgery that can impact the functions. We also acknowledge other factors that could be involved, certainly various other factors relating to erectile dysfunction generally, and we also mention some of the health comorbidities that are related to having erection problems, even if you've had a prostate cancer surgery. Next slide. Other factors I bring to your attention because I think that this is important for the group here to understand that we do have some control over our bodies and our health status, including erections. And yes, there are adverse health conditions and treatments such as prostate cancer treatment that can be largely responsible, but there are other factors as well, including how well we live our lives. Are we getting enough exercise and keeping our cardiovascular system healthy? Are we staying in good shape and keeping our weight in a good shape? Are we doing any adverse recreational or other active substances that may negatively impact erections? So these are important issues to be aware of as well. Next slide. Now, in terms of managing erectile dysfunction, again, it's a subjective complaint, and I have for years stated that patients participate in their best care for this problem. We recognize there are underlying conditions that should be treated, but to manage the erectile dysfunction specifically, we have to ask the patient to participate in that management. And we call this goal-directed assessment. We now use the term shared decision-making, and we inform the patient of their options, understand what their needs are, as well as the needs of their partner, their expectations and priorities with regard to various forms of treatment that we can offer. The partner has a very important role, and we recognize by various studies that yes, it's not just a man's problem, it's a couple's problem. So a partner for a man certainly participates potentially in the sexual activity and can impact the best decision making that should be offered. And studies have shown that this can occur as much as 58% of the time. What does a partner offer? Well, as you can see here from the slide, that person is a participant and can bring insight and perspectives to the relationship as well as sexual issues. So what is the treatment of erectile dysfunction? And I've counseled all my residents and fellows over all the years that we recognize that every man may have, again, unique aspects to his erectile dysfunction. So we want to review how symptomatic it is for him. There's various degrees of erectile dysfunction, how much he's stressed about it, what other health conditions are in play for him, aspects of his relationship, and perhaps even the socio-cultural context. That is, understanding a person's cultural background that may also impact how they want to proceed with care. And then all treatments can be offered, but we also understand what may be contraindicated. You'll hear about that as I give you a review of what options we have available. And of course, as I mentioned before, understand the underlying health conditions, and addressing these may also have the benefit of improving a man's erectile function. So we kind of use what's called a step care approach. And this slide nicely shows this. We obviously review the man's health history, do a physical examination, including the genital area, which helps us understand whether there's any deformities in the penis. I mentioned Peyronie's disease, which is a scarring process that many men acquire as they get older. That can deform the penis. And then we do laboratory tests where necessary. And there are laboratory tests that can inform us about underlying health conditions. If they have already been done with the help of a primary care doctor, that's helpful. But this just lists a variety of tests that we may do that helps us about glucose and insulin, lipids that have to do with cholesterol and cardiovascular system, screening for other endocrine problems, including even screening for a man's hormone levels that may have more to do with libido than erections, but may nonetheless be helpful to study. And then, as mentioned now, we involve the patient and partner if possible. We engage in this shared decision-making process, which is, I'll discuss a little bit more, but a manner of partnership with the patient. And then review the therapeutic options. And if necessary, and the reason I put therapeutic options is I counsel patients as well as other colleagues that any healthcare provider can help with a man who presents with erectile dysfunction. In certain circumstances, a specialist is required to carry out various kinds of diagnostic tests that may be a bit more complex, perhaps in challenging presentations of erectile dysfunction. I also make the point here that a mental health professional can always be helpful, even though there may be situations where a man has a true organic problem, a physical problem with very clear comorbidities or health conditions that we can recognize, diabetes, cardiovascular disease, and so forth. It still could be a potential benefit to have a counselor involved. I've suggested to many patients who may come to me who have even had erectile dysfunction after prostate cancer surgery, that while I may get involved to address helping them get a better erection, it may still be a benefit to see a counselor or a therapist if you're having issues that relate to your relationship, anxiety issues, and so forth. And this sort of person can always be of value to help us with managing that patient, understanding the patient as a whole and not just helping his penis alone. So next question. If any, which of the following have you or your partner tried to treat ED? Answers: no treatment, oral medications, couples or sexual therapy, or other. And the profile of results are that as much as 86% of the audience is using oral medications. At the same time, 9% have no treatment and 5% have couples or sexual therapy. So I think this is probably consistent with where we are in the modern age of having oral therapies that have been introduced to treat erectile dysfunction, and overwhelmingly, this may be an initial treatment for the majority of patients, 86%. So let's get into what are our options for treating erectile dysfunction. This slide presents what we have called the process of care, meaning that we have considered what are the options that we currently have available that may follow kind of a paradigm of what's least invasive as first line, what's more intermediate second line, and what is tend to be a bit more invasive as a treatment on the third line. Okay, and I'll just briefly mention these, but walk you through these with the remaining slides of the talk. Obviously, oral medications, which 86% of the audience has had exposure to, including these agents that you are familiar with, called PDE5 inhibitors, Viagra, Cialis, Levitra, Stendra. I'll get into this in a moment, but these have revolutionized the treatment of erectile dysfunction, very effective therapies that are oral. Along the way, as mentioned, a mental health counselor can be of benefit in first line management. Second line are treatments here that are done a little bit more intrusively to the genital area, but they're non-surgical. Okay, non-surgical options, and I'm going to break those down for you in just a moment. Third line refers to surgery, and this involves putting a device inside the penis that could be a complex inflatable device, which is kind of shown here, or some of the less complex ones that just have just a small bulb or even no bulb to inflate the device, here being just the one you bend up, bend down type, a malleable device. So let's get into these in a little more detail. All options are shown here, okay? And as we have modified our thinking over the years, we used to teach patients that we would walk you through first line, then second line, then third line. And we recognize that it perhaps is smarter to counsel the man, use shared decision-making, have all options on the table, and recognize what are the risk factors and severity of the erectile dysfunction and the wishes of the patient, understanding that in certain situations, it may be more smart to just move forward with perhaps more invasive options that are going to be effective. And so this is to say, for example, a man who's had a major motor vehicle accident, had major pelvic injury, and we know that his likelihood of responding to oral medication is very low, and we counsel him to say, let's not frustrate you with oral medications for a few months. You may have to understand that you will have to consider something that's a little bit more involved and even a surgery. So in other words, fitting the best condition with the treatment that will address the problem and lead to effective outcomes. So this just gives you a glimpse of how we've gone forward now to understand our treatment options, and again, use a paradigm that's evolving from just saying each man has to walk through every option, but rather explore the option that is most effective. Next slide. So we have the oral pills, and this is a time cover from 1998, believe it or not, that introduced the oral medications. Next slide. So let me tell you what these are. Type 5 phosphodiesterase inhibitors. The blue pill, you've heard that. The ads have been out there on TV and so forth. And just to mention what these are oral pills. You have to take them orally. They require sexual stimulation. They do work in about 70% of sexual attempts, but not all the time. There may be some minor side effects that patients can experience. But again, it's thought that this augments erections, meaning that some level of erections are occurring to which this medication works through the pharmacology, or really the mechanisms of how these drugs work, that they augment erections. And that's important because I want patients to understand that if your erections are fairly poor, this may not work well. And that's why these pills do not work so well in diabetics who have very poor erections, or maybe even men who've had a prior prostate surgery, particularly early in the recovery, where erections are very poor, because they really work to augment erections. And that's the key principle I want to share with you. In terms of contraindications, it should never be used with patients who are using nitrates in any way. So nitroglycerin or nitrates for cardiovascular health issues called angina, chest pain with the heart, should never use these. And then we also have considerations with medications men use for urinating, commonly like Flomax or Urethral and others, that there's concerns with any of these kind of medications that they could make you feel lightheaded or drop your blood pressure, and certainly very serious with nitrates. So this is important to be aware of. And this just makes the point here that there are different drugs out there. They have different characteristics, and this can be discussed in greater detail with a personal session, the time of onset, how long they work, and impact of food. And so this gives you a sense that we have different options out there. Next slide. Second line, these include vacuum constricted devices. I'll show you that in a moment. Injections of medication to the penis with drugs that create erection responses. And they can be different drugs, even in combination, called trimix, 3 drugs mixed together. There's even the intraurethral suppository. It used to be called new, so it's fading now as an option. I'll tell you why. And even the idea that putting creams and gels on the penis, isn't that something that might work? But let's go on to this. Next slide. Here's an example of a vacuum device. And this is one of the early kinds of devices, but they're all very similar, with a cylinder that's brought over the penis, kind of creating kind of a seal at the base of the penis. And then this whole system creates a vacuum whereby it draws blood up into the penis. A constriction band is released to the base of the penis to hold that engorged blood. The whole apparatus is then removed, and that man then has an erection-like state that he can use for intercourse. Next slide. So it works by a kind of a vacuum effect or negative pressure mechanical drawing up of blood in the penis. A man should be taught how to do this. It does have success. The reason why satisfaction rates are a little bit lower is some men are not entirely pleased by the unnatural feel of this kind of erection. The fact that it can pivot somewhat because of the constriction band, it doesn't really fill out the entire penis, more internal to the body. And therefore it can cause some bruising sometimes, even a sense of coldness because of just kind of this effect of this mechanical device. In certain disease states, we have to be a little bit concerned about that it may cause some problems. But again, this is a very successful option, external, and can be brought to bear if a man wants to explore this. This makes the point about this option I mentioned called MUSE, medicated urethral systems for erection. Now, this is a therapy that was introduced in the mid-1990s. It's faded now in the past 10 to 20 years. Why? I'll tell you, but it basically involves delivering kind of almost a big pen where you depress the end and a little pellet comes out inside the urinary channel. And it's thought that within the urinary channel, it gets absorbed into some of the erectile tissue and finds its way to the main erection bodies of the penis called the corpora cavernosa. So that's the strategy of this therapy. Next slide. So this is thought to be more of an inducer rather than augmenter of the erection response. It does require training. We use an agent called alprostadil, a vasoactive drug that has been formulated as a little pellet. The response rate is so-so though, and that's the issue. It requires this absorption, that it has to be absorbed as a medication into the urinary lining and then find its way to the rest of the penis. And in many men, the way their penis, the tiny vessels in there don't always make this very successful. There are some concerns about possible injury to the penis and so forth. So this is largely fallen by the wayside because of lack of effect, but I just wanted to share it with you so you're aware of this option that is out there. Now this shows penile injections. Now, I don't think I've ever met a man who's told me he's been excited about putting a needle in his penis, but this truly is an option where using a diabetic syringe and a tiny diabetic needle, you can deliver the medication to the main erectile bodies of the penis. This requires training with a vasoactive drug that can be injected, and we teach men how to do this if they're inclined to do it. Next slide. And again, this induces an erection effect within the main corporal bodies of the penis that produce erections. It requires training, and we want you to do it safely. And we also know that there can be some potential for side effects. If it's not done correctly, there could be some penile pain or scarring in the penis. Some men may over-inject, and that's called priapism. You heard me mention that before. So all of this, I think, is largely averted by a good training session and making sure that a man knows how to do this safely and within the range of the medication dosing that we want him to use. And then going on to the options here, you can see there's various drugs that we use, various terms. If you've heard out there, Cabroject, or even Bimix and Trimix and so forth, these are various combinations that have efficacy rates that range as much as 90% with various drug combinations that we can use to achieve erections for that man. And now a penile prosthesis. This is the Cadillac, if you will, the 3-piece inflatable device surgically placed in the penis. Nothing is sticking outside the man when he heals up. He looks like a normal man. The 2 main cylinders of the penis, the pump within the scrotum, a reservoir that's inside the abdomen behind the pubic bone, all connected by tubing. So nothing interferes with solutions and body fluids, but this is all put inside a man's body. And basically, this is perhaps for a more severe form of erectile dysfunction, when there may be injury or deformity of the penis, and we have to do some sort of penile reconstruction. Oftentimes, when medical therapy does not work or is unsuccessful or not interested by the patient, it provides an internal splint for the penis, and everything else about the penis is intact, including sensations and ability to achieve orgasm. Simply enough, it provides a splint or a means of rigidity for sexual intercourse. It does require some training and understanding how to operate the device. There are some potential for downsides, a 1% risk of device infection, less than a 5% risk in time of any kind of device malfunction. But these are great options for the right candidate who understands what it has to offer. We know that it has great reliability, 10 years. These devices are very functional, and patients largely are satisfied with it. And the key to that satisfaction, and I believe this very strongly, is we take time with patients to understand what the penile prosthesis does, how you use it, and what its expectations are all about. And when they're carefully selected, patient success rates are high. Now, I put in a couple other slides toward the end here because you may have heard about shockwave therapy. What is that all about? And this is being advertised. I just want to inform you that this has some scientific basis to it that has been used in various forms of therapy. It's thought here that maybe in the penis, you can use sound waves that can lead to healing and create blood vessels that vascularize or heal up and create new blood supply to the penis and make the tissue in the penis heal better. That's the logic. And perhaps there has been some evidence in other areas. And the idea is you can just use a little probe on the penis and create shock effects with treatments in a clinic, and maybe that will be helpful. The bottom line is that, and I know this is a complex slide with a lot of words to it, but for those who are interested, you can read it more completely. But the message is to share that while this has been an area of interest, there has not been enough randomized controlled studies, randomized controlled trials that have scientifically established how successful, what patients should be using it, whether there are any potential risks to patients. So it has to be stated that we're still awaiting good studies to show how effective it is, and there may only be a select population of patients with more minor forms of erectile dysfunction that likely stand to benefit. So hopefully that's the message that I can share with you, to be aware of this therapy. And major guidelines and major organizations, it is still thought that this is still an investigational therapy and is not in our standard list of therapies as I showed you before. In the future, I think we're going to move forward with new ideas, with new medications as we understand the science of penile erection. We may develop new surgical techniques. We're even talking about doing tissue transplants. And I was the surgeon involved with our penile transplant here at Hopkins here just 3 years ago. And we think that this may be a direction for those who even have complete penile loss. And how do we help those individuals regain some level of function? So we're working on that. We're working on new devices that may even be simpler to use and that are surgically placed within the penile area. So all of these are exciting new developments, and I just wanted to make a brief remark on that. So what is the follow-up here? Well, the follow-up is when patients get initially treated, you may or may not respond to that oral therapies, for example. Some patients may find that it did work for them. Well, that's wonderful, terrific. Others, it has not worked, and they need to be counseled that, yes, come back in, let's think about other options. There are second line options, as we call them, or even third line options, but all these are options that can be explored beyond the least invasive oral medication. And we will try to understand how we can move forward with alternative therapies and achieve patient responses and satisfaction. Key points of the talk. As I mentioned, you're not alone if you're having erectile dysfunction. This is common. 1 in 5 men who are adult men have erectile dysfunction. And we do know that even as the men age, the incidence goes higher, as much as 50% of men above age 40, 40 to 70 start to have degrees of erectile dysfunction. But this is for all men above age 20%. There's a basic evaluation. We evaluate the man, we understand his health history, examination, laboratory tests, and then move forward with an informed shared decision-making process, combining the goals, preferences, as well as the patient and partner, review all of the options, and try to figure out what is the best option that fits with the extent of the problem and the interest of the patient and partner. So stop showing off your walking stick. But we want guys to be functional if they want to be functional. Next slide.
Thanks, Dr. Burnett. So just a reminder to attendees, you can submit your question using the Q&A feature at the bottom of the Zoom toggle window. But we do have a few questions here to get us started. First question is, are there cases where ED is not treatable?
So the question is there cases where ED is not treatable? And the answer is, I would venture to say that we can treat any form of a man having erectile dysfunction, insofar as even a man, like I mentioned, a military veteran who lost his entire pelvis and we reconstructed him, and now he's functional. So even loss of the penis altogether. So the answer is with our current technology, we can treat, I would say, virtually all forms of erectile dysfunction with the therapies that we have.
Thank you. Second question is, do diet and exercise play a role in treating ED?
So the question is diet or exercise important? And indeed, this fits with my discussion of lifestyle factors, whereby a patient can take control of his health, not just for his erections, but for his overall cardiovascular health, his blood pressure, his metabolic fitness, by taking action. And yes, a better lifestyle of exercise and better diet, I think, does have dividends with regard to preserving your best erections. A big question is out there as to whether that fully reverses erectile dysfunction if you get very healthy. And I think the literature would suggest that if there has been enough long-term dysfunction, that may not fully correct the problem, but I do recommend still a good health lifestyle to preserve your best function, to go forward, and then work with any specialists to consider additional treatments on top of lifestyle activities.
Great. Next question is, what about herbal remedies? Can they be helpful for treatment?
So the question has to do with herbal remedies, and the answer here is that herbal remedies have largely fallen out of favor by most experts in the field, just because they just don't have any proven efficacy. In truth, back when I trained here in the 1980s, we used to write for various kind of herbal remedies, including such agents as yohimbine. but we didn't have anything better. And of course, there may be some chemical effects of these drugs in the body, but largely they're not very effective and they've not been studied well. And there are concerns regarding the safety of some of these agents as well. So I would say at this point in time, I think getting a sound counseling by a specialist or a sexual medicine doctor or at least a health doctor is a smarter way to go. I'm quite a bit leery about these supplements and herbal therapies out there as to their safety and efficacy.
Next question is, how long after radical prostatectomy can one reasonably expect some reoccurrence of erections?
So the question has to do with radical prostatectomy and erection recovery. And again, where this is a case here, as briefly discussed in the presentation, that treating prostate cancer by way of surgery can have impact at various levels in terms of the surgery impacting nerves and blood vessels, as well as just other factors that may be involved in that man's health history and perhaps his overall response to having a situation of a condition such as prostate cancer. As far as with that context in mind, know that the surgeries that us surgeons do can impact structures in the deep pelvis that have to do with how blood flow occurs in the penis, principally the nerves. And these nerves, while we dissect them away from the prostate, these nerves can get shocky for as much as 12 months or longer. So it is important to understand that when a man undergoes treatment with prostate cancer surgery, these nerves, while even delicately dissected well, using the technique of Dr. Walsh, who was my chairman and mentor about how we do these radical prostatectomy surgeries better than they were in the pre-era of 1980 and before. Since the mid-80s and so forth, we've been doing these surgeries a whole lot better, past 30 years, let's say. But even when we do these surgeries very well, even with modern techniques of robotics or even very good technical surgical open approaches, these nerves get shocky. And it may take 12 to 24 months for erections to fully recover because these nerves are shocky, even though they're not truly damaged or transected or cut or anything of that sort. They just kind of lay dormant there. And these nerves regulate blood flow coming into the root of the penis, causing erections. So the answer is 12 to 24 months, and that is why the nerves have to recover.
Thank you. Next question is, what are your thoughts on combo drugs such as Rutagay or the slide fill plus Tadalafil? I may be pronouncing that wrong.
Can you spell Rutagay?
Rutagay, Rugiet.
Well, that may be a trade name, but the combination therapy is the question. What are our thoughts about combining treatments? And the answer is that is an option. I think it has to be done under some supervision because you may end up with a prolonged erection effect that could be dangerous. And I use the word priapism, a medical term. And the reason why that's important is because a prolonged erection effect can lead to damage because of lack of circulation with a prolonged erection. But combined therapies can be considered. And again, I think it's safe to do it under supervision. Combined therapies can include using a vacuum system, even with injections, and men who may need that kind of combination, or a man who may even use oral therapy, thinking it just adds a little bit of something to you having a penile prosthesis already there. Certainly, the idea of using oral therapies and injections, which are both medications being delivered to the body, is a little bit more unclear, because really, if you're doing injections, you're already injecting kind of a liquid form of Viagra, Tadalafil or whatever that there is. Tadalafil is Cialis, and there's other ones here that are all these agents that are very similar, the oral agents. You're doing all of this by injection, and then having to deal with the additional expense of taking an oral agent may not confer much additional benefit. So the key here is how well do these things in combination produce a better outcome and also avoiding side effects.
Great. Next question is, are there any recent viable surgical treatments developed for Peyronie's disease, which do not have the significant of earlier surgical techniques?
Well, yes, we can talk about Peyronie's disease briefly. So I mentioned Peyronie's disease for the rest of the audience who may not be familiar with the question. This again is a penile deformity that is acquired largely in men getting in their 50s and 60s, almost an arthritic condition of the penis. It's not cancer, but it's just kind of scarring that can develop in the penis. And we think it may just relate to just getting older and just having erections where something in the penis just with an erection or during sexual activity, something kind of pulls or shears in such a way that a scar develops in the penis. And it can be very profound in some men with curvatures and deformities and shrinkage of the penis and all kinds of things that really deform the penis in very profound ways that can disable a man from maybe even being able to have a penis that could be used for sexual intercourse. So the question here is how have we evolved therapies, surgeries, for example, and the older therapies for Peyronie's disease may have been a bit more primitive. They may have involved dissection in ways that may have led to further damage of the penis or loss of some sensations in the penis, things of that sort. Yes, surgeries have evolved to be even more precise, to do surgeries with more precise materials and surgical techniques. So just in generalities, yes, we are evolving better therapies. Ultimately, it'd be great if we had a non-invasive therapy that could help with scarring and relieve some of that and regain the normal structure of the penis. We're not quite there yet, even though there's something out there called Xiaflex, which is an injectable form of an enzyme that breaks down scar tissue that is called collagenase. The success with that is, I would say, modest, and patients need to understand, does it really fully correct the problem? It may help somewhat, but not fully. So men have to understand that. So yes, the field is evolving, newer surgical techniques with greater precision and newer grafting materials and other kinds of materials that surgeons can use to achieve better outcomes.
Great. We also have a question around diabetes. The question is, if you are currently suffering from diabetes, is it possible to regain the ability to have an erection?
So the question has to do with diabetes and erectile dysfunction. And you heard me mention that throughout the talk, that diabetes is a common condition that leads to erectile dysfunction. In truth, as much as 70 to 80% of men with diabetes do have erectile dysfunction. Diabetes impacts nerves and blood vessels. And so the truth is yes, please get your best checkups if with your regular doctor or even a diabetologist. Control your diabetes as best you can. I have seen men who have had very poor diabetes control, and once they get that better control, they do regain some level of function. But that is less common. Once diabetes gets a little more serious, damage can occur and just gradually worsen over time. And therefore, many men with diabetes may need to move forward with some of the proactive therapies that I've mentioned here in this talk.
The next question is, what causes oral erectile dysfunction drugs not to work or no longer work intermittently?
So the question has to do with the failure of success with oral medications. And the cause for that has to do with the fact that these oral medications augment erections. That means there has to be a certain level of integrity of the blood vessels and nerves that these medications work scientifically to boost. And if a person's blood vessels and nerves are just not quite at the level that they are producing some partial erections at least, then these medications become less effective. Now, why do these drugs work intermittently? Well, a lot of factors may come into play. And I always counsel men using oral medications to be aware of the best circumstances for them to respond to these medications. Sometimes if they have a very stressful week, maybe they need to wait to the weekend to have sexual activity. If they have a very exhausting day, physically they're just not strong that day. They may know that their function is better maybe earlier in the day than later in the evening sometime. So all of these are factors. Another factor I mentioned on one of the slides was food intake. And if a person has a big meal in their stomach, getting the oral medication to get absorbed into the body and have an effect with circulation to the penis may be hampered. So all of these are factors, not to mention using the most high dose of the medication if you're using a less than full dose. So all of these things I think are nice little optimization techniques to really respond to the oral medications, but also understanding that they work primarily to augment erections whereas the other treatments have more of a role of inducing erections or creating erection, even if there's no erection response naturally.
Next question is, what are the systemic effects of injections into the penis?
Question has to do with systemic effects of injections to the penis. Systemic, for those less familiar, means what happens when you inject to the penis, and systemic get into the whole body system. Does it necessarily have adverse effects if you inject right in the penis? It could harm you elsewhere. And the answer is that these drugs have been studied very carefully. They're thought to be very safe. At the low dosages that we use injected in the penis that can have effects just to create an erection response, the likelihood of having effects elsewhere in the body are almost negligible. Yes, if you inject excessively, something could occur with these drugs that make blood vessels open and might get in the body, but then you'd have an excessive erection effect, and that would be very troubling too, right there. So again, we avoid these kinds of adverse effects with careful counseling, instruction of how to do the injections and to do them with proper dosing. But largely, systemic effects do not occur with penile injection therapy.
Great. The next question is, what type of exercise or physical therapy can be helpful? And if there are any specific types of exercise?
Well, in terms of physical exercise to be helpful to help with preserving a man's erections, the answer is general physical fitness that we would do for our cardiovascular health. So there's no specific exercise that is as a surgeon and specialist in terms of a man's genital health that I would say. Nothing specific to the penis that I would inform you to do exercising the penis per se. Rather, we're talking about just getting your general body health fitness with exercises that could be as basic as taking your 15 to 20 minute walks every day, or getting a level of fitness with whatever you find is of appeal to you, bicycle riding or going to the gym and doing some cardiovascular health fitness and things of that sort. So what we're talking about here is just basic health fitness that does have the benefit of the cardiovascular system that can affect and impact the penile vascular system as well.
So I think we have time for just 2 more questions. So the next question is, what can be done to improve the recovery of the nerves post-surgery, which as you say, are shocky?
Yes. Well, thank you for asking that question, as all the questions, I thank all of you. This has been kind of the $64 million question, if you will, that we've been asking for years. What can we do as scientists and specialists in this field to do a better job of helping these nerves recover? We're still trying to study the science of this. In my research laboratory for the past 25 years, we're investigating really what's the basis of the nerves getting shocky, what are the underlying molecular factors that have to do with this, what kind of factors can we target and try to make these nerves recover faster. We've had some leads here and there, but the science still is ongoing. And we still need to figure this out and develop it into true therapies that we can bring to patients. So that kind of work is still ongoing. We think there may be some leads that we have, but we still have to continue to work in these areas to bring forward perhaps interventions that may be implemented at the time of a surgery that can help these nerves be less shocky. We're working in areas such as stem cells, new pharmacologics, and so forth, that we think will have benefit, but we still need to do the trials that sometimes take years to complete. So that gives you hopefully some sense that we're committed to this kind of work as well. We understand what needs to be done, but we still need to figure this all out and bring it to our patients to have the best outcome.
Great. Our last question today is, how do you diagnose if the ED is due to nerve or vascular damage caused by diabetes?
So the question is diagnostically, that is using tests and whatnot that we have for a diabetic, how can we make sense out of what's the underlying real issue with that person having erectile dysfunction? And with that thought, the studies that we do can evaluate blood flow effects in the penis. we do a test called penile ultrasound studies, penile ultrasound studies, that is using sound waves, like sound waves with a mother with a baby in her belly. We can actually study the penis with inducing erections with drugs, as much as we do, as I showed you with the penile injection therapy, and study how well the blood vessels respond. And we can use a little ultrasound probe right on the penis and see how the blood vessels react. And that's our best way of determining whether a person's blood vessels are functional or not. And we may do that with diabetics or other kinds of conditions presenting with erectile dysfunction to get a handle on really how impaired the blood vessels are there in terms of their function. In terms of nerves in the penis, we induce, or at least infer that, infer that nerve function is impaired in patients in which we find that the blood vessels react very well, and we have a sense that nerves are not working right with various kinds of sensory tests in the genital area, or just reviewing some basic neurologic testing that we may otherwise do. Keep in mind that our options for management at this time here in 2021 still are fairly basic, and they're offered irrespective of the exact nature of the problem, whether it's a nerve problem or blood vessel problem. As you saw, the treatments we have to offer, we offer them almost by way of what does the patient want and the severity of the problem by and large. So perhaps in the years to come, when we have specific medications or other medical therapies that may be specific for helping blood vessels heal better, nerves heal better, as I mentioned, for prostate cancer surgery, and then it'll become very relevant for us to understand the exact underlying damage and how to take action. But for a diabetic, up front, I will tell you, please get your best checkup, stay on your medications to keep your blood sugars under control. That is perhaps your most effective intervention. And then if necessary, come see us, and we're glad to work with you to move forward with the therapies we have available for erectile dysfunction.
Great, thanks, Dr. Burnett, and thank you everyone for attending today, and we apologize for our earlier technical difficulties. If you would like to learn more about the services offered and how we can help you, you can visit hopkinsmedicine.org/urology or call to make an appointment at 410-955-6100. Thank you again.